Okay, I hope the screen is visible. So without further ado, I think the first case I'm presenting. So we can start off with our with the session. So once again, thanks everyone for joining in and sending in your cases. I think we have around 10 cases today, complex spectrum of cases. So chat is open, so feel free to put in your suggestions and comments and possible diagnosis and help us out in these cases. I'll start off with the first case. We had some genetic. Yeah, so we had some genetic workup done for this case scan last year, but we'll go through the case startingly. So this was a 1 year, 9-month-old female child who presented with global developmental delay and visual impairment. Child had a background of seizures, first seizure June last year with a second seizure slightly brief in episode in December 2024, that's last year. Other developmental concerns were child was not tracking to light, but was turning to sounds. Cognitive and language skills were equivalent to 7 to 8 months. So again, there was some delay over there. Fine motor skills were equivalent to 3 months. So severe fine motor and gross motor delay. On examination, child had good neck control, preserved weight bearing, and some degree of ataxia was present. With that background, the child was scanned, I think, at the age of 1 year, that is last year. And these are the selected images of the child. T2 axle images, T2 sequences out here, T2 axle on top. And you can appreciate that there is pachygyria along the bilateral hemispheres, generalized pachygyria more along the frontal parietal lobes. Coming down, also there is some patchy hyperintensities in the basic ganglia, possibly Wachterhausen spaces. As you can also see in the deep white matter and the juxtacortical white matter, some prominent perivascular spaces. Myelination is slightly delayed for a 1-year-old. The anterior capsule is not myelinated. Subcortical white matter also in the parietal regions and also some degree of occipital lobes do not demonstrate optimal myelination. Along the posterior fossa, the most prominent findings you can see is along the brainstem. You have this tiny bump of the ventral pons, severely reduced in caliber. Some degree of hyperplasia also of the vermis out there. The fastigial recess is not as pointed as what we usually expect. It's an obtuse angle fastigial recess. Corpus callosum is also abnormal. You have some drooping of the isthmus and splenium of the corpus callosum with reduced volume. And if you look at the axial images of the brainstem, you have these grooves along the brainstem, particularly on the ventral aspect. Some degree of abnormal foliation in the inferior silver hemispheres. Yeah, so overall a malformative kind of pattern with some degree of delayed myelination, predominantly affecting, you have this lissencephaly or pachygyria type pattern, severe hypoplasia of the pons, and also some dysplastic appearance of the corpus callosum. With that, I think we suggested some genetic abnormalities for this case. And so before moving on, these were the imaging clues which were helpful in possibly diagnosing this case. If you look at the PCH spectrum, you have this peculiar appearing pons, which is relatively seen only in few disorders. MACPI1 is the most common one, presenting with this peculiar pontine abnormality, as you can see over here, which resembles our case. This is again from paper from Dr. Bolthauser. If you have PCH with cortical malformation, especially simplified Gallal pattern or lissencephaly, again, MACPI1 is one of the disorders presenting with this abnormality. And yeah, here are some published cases. I think the first one is again from Dr. Bolthauser. You can see that the imaging findings are pretty similar to what we have seen in our case. Other examples also, we have these typical peculiar appearing pons, brainstem grooves, and cortical malformation on top. The other variant or the other gene which can somewhat resemble this one is the RHGF2, though I think only one case series or one case have demonstrated these findings. So with that, we thought of possibilities of MACPI1 and ARGF2 as possible causes for this case, more likely MACPI1. And then the child was tested genetically. So the child had a MACPI1 variant of uncertain significance, and later on the parents were tested. And the parents had an were absent carriers for this gene. If Apurva or anyone can take up the genetic analysis, what is the significance of the variants or any of the? I don't think Dr. Srikanth is there.
Yeah, so it is autosomal dominant in the child, and parents don't have that. So it's a de novo mutation. It's a likely match based on the radiology, and even genetic wise, there's no it is de novo.
Excellent, thanks. So yeah, we agree with Apurva and Ivan. If you want to have any comments, I think we had discussed this case previously too.
I think you have very well explained and show the illustrations. This MRI is, I think, diagnostic. So it's, as was said, this is a perfect match. Clinic-wise, imaging, genetics.
Anyone has any experience with these genes? Similar cases? Bow tie sign, Sridhar, yeah, okay. A possible sign there.
I mean, in theory, one of the parents could have a germline mosaic, so it's still possible to discuss prenatal diagnosis, not to overlook this germline mosaic, which will not be found in peripheral lymphocytes.
Got it. Okay, thanks again. Yeah, we just wanted to highlight the case and the genetic analysis with the clinical match and also the radiological match. If there are no comments, I'll quickly move on to the next case. All right, so this again, I'll be presenting. This was, I think, one of the parents is a physician, and he wanted me to discuss this case. I'll not disclose the details of the child or from where it is, but this was a 10-year-old female, was born by elective LCS with birth weight of 2.1 kgs, had unremarkable neonatal period, normal development until 7 months of age. After which she developed severe pneumonia requiring hospitalization and oxygen support, followed by 3 months of irritability, and was known to have labeled to have a mild developmental delay. At the age of 1 year, MRI brain was done. I don't have the images of that brain, but it was described to show T2 hyperintensities in the thalamus, and the EEG was abnormal. Physiotherapy and supportive medical management was advised. She later developed febrile convulsions at the age of 3 years. Again, abdominal EEG. I don't have the details of the EEG. And received 3 days of clobazam and was discharged without any antiepileptic maintenance. Physiotherapy and speech therapy continued. That's why at the age of 10 years, again, the child was being evaluated for precocious puberty. Repeat CT and MRI, which I have the images, which we'll see in subsequent slides, had significant abnormalities in comparison to the initial MRI. And functionally, she had demonstrated progressive developmental improvement over the years, now showing mild spasticity in the upper and lower limbs, with mild motor delay, mild speech issues, and but complete understanding and scoring more than 75% in school with good verbal performance and normal visual, apart from the mild squint. Normal hearing, ability to walk and run, and overall good cognitive adaptation despite neurological deficits. So this is the CT. I think was done a couple of years back. And on CT, you can appreciate this dense course-like calcifications, again, predominantly centered in the deep brain nuclear structures, some abnormalities in the subcortical, deep juxtacortical parietal white matter out there, going up to the subthalamic nuclei and also involving the posterior fossa structures in form of the dentate nuclei. You can appreciate dense calcification out there. Some white matter abnormalities, as you can see, there's confluent hypodensity along the cerebral white matter on both sides. I think will be better appreciated on the MRI sequences. So with that CT background, an MRI was done recently. I think this was done last week, if I'm not mistaken. So on the MRI, you can again appreciate confirmed abnormalities involving the cerebral hemispheres, relative sparing of the subcortical white matter especially in the frontal and temporal perisylvian regions, but going up in the parietal regions. And the SWA sequences or the T2 sequences, you can appreciate the corresponding low signals on the T2 weighted sequences showing hypointensities. So these are calcific foci, which was seen on the CT. Again, so again, dentate nucleus changes you can again appreciate on the both sides, more on the right side. And these are the SWA sequences. I have not put in the outphase sequence, but I can confirm that these tiny punctate areas are microhemorrhagic foci, do not correspond to calcification, whereas these dense areas in the deep brain nuclear structures and dentate nucleus correspond to calcific foci. So a mix of microhemorrhagic changes, dense calcifications, leukoencephaly-like pattern, and precocious puberty, as the thalamus, the cellular and supracellular structures were normal. There's no T1 pre-contrast, but the T1, the cellular structure, the pituitary gland is normal out there. And on post-contrast sequences, there was some enhancement along the parietal abnormality, some peripheral enhancement along the calcific foci. But yeah, these were the main findings on the post-contrast sequence. With this, we had suggested, then follow-up was done, and all the labs, thyroid function tests and related endocrine abnormalities, endocrine parameters were normal. Bone age X-ray was done. I think that was also demonstrated normal for age. With this, with everything coming out to be normal, genetics was sent last week. We await the result. We thought that possibilities of CRMC-related disorders, microangiopathy such as CTC1, STN, Coach plus or Labrun on the imaging findings were a possible match. Those were not present at this point of time, but the calcifications, leukoencephalopathy, microangiopathies were, I think, possibly correlating with the disorder. FAR disease and hypothyroid-related disorders, maybe the calcifications can be present, but the microhemorrhage changes and the leukoencephalopathy is not usually seen in these changes, in these spectrum of abnormalities. So we wanted to discuss if there are any alternate possibilities, whether we are dealing with a genetic disorder or and the parent has specifically asked if can this be a post-infective sequelae as the child had a neonatal or early infantile infections. Yeah, so these were the main questions. And if anyone has any comments, we're open.
I have a comment. I was involved in 2 patients with very similar imaging and surprisingly very extensive calcification and minor clinical findings. And as was already discussed in the chat, LCC, leukoencephalopathy, calcification and cysts is top on the list. Not all patients have cysts. This depends on the age. And this is a recessive gene called SNORD118. And it's important to realize this gene is not a protein coding gene and can be missed on normal exome sequencing. So the geneticist should know exactly about your suspicion. And also an interesting finding is that all patients are compound heterozygous. There are no individuals with homozygous variants. This is an interesting observation. This is a similar observation like in LBSL. All patients are compound heterozygous. So LCC is top on the list.
Yeah, thanks again. LCC or Labrun, I agree. So we are thinking of genetic. All right, let me just see. Dr. Nasha, do you want to speak or? Okay.
This cerebral folate deficiency also has calcifications, but not that chunky. But yesterday only I was discussing a case with one of my colleagues at Kokilaban Dhirubhai Ambani. She sent me a similar CT and it somehow came to be cerebral folate deficiency pathogenic variant. Just thinking out loud, but I have not seen such cerebral folate till now. But Saili, one of my colleagues at KDH, she saw one. It turned out to be cerebral folate. And one of the monomer neurotransmitter also presents with this sort of calcifications, but I'm forgetting the enzyme.
FAR disease is not really an entity. I don't think we should use that name anymore.
So idiopathic calcification.
Progressive familial brain calcification syndromes.
Yeah.
PFBC spectrum.
So do we agree that likely genetic diagnosis and we wait?
We are interested in feedback.
Let's see. I think Dr. Nasha wants to. Dr. Nasha, do you want to say something? Let's see, you have raised your hand. Okay, you can put it in the chat if you're unable to speak. All right, so we agree that a likely genetic abnormality, and we await the results. Less likely to be a post-infectious or an acquired sequelae. Okay. And just to put it out, the cerebral folate deficiency review article is being submitted by the Great Ormond Street group, so we hope to be educated by that. All right. Thanks, Amina. Yeah, cerebral folate can have calcification, but I think the entire spectrum of disorders was slightly may not be typical. Okay, so no comments. I'll move on to the next case. Yeah, Nikesh, over to you.
Yeah. Am I audible, sir?
Yes, go ahead.
This is a case, 2-day-old late preterm, 35 weeker, female infant. Birth weight was 2.08 kg. She was born to a primary mother by normal vaginal delivery with no prolonged labor. The child didn't cry soon after birth and had low Apgar scores, 1 at 1 minute and 3 at 5 minutes. The child developed severe respiratory distress soon after birth, and she was given positive pressure ventilation, following which she was intubated and shifted to another hospital. On first day of life, she developed seizures, and she was started on levetiracetam. After that, there was no noticeable seizure episodes during the hospital stay. On second day, she was extubated and shifted on the nasal prongs, and after that, she was transferred to Rainbow Hospital for the further workup. Maternal history was not significant except for premature rupture of membranes for 2 hours. During
Sorry.
NICU stay, oxygen. Yeah.
There is some background noise. Can people who are not speaking mute, please?
Okay, please go ahead. Yeah, just muted. Yeah.
During the NICU stay, oxygen was gradually weaned off over 4 days, that nasal prong oxygen, and baby was continued to receive intravenous levetiracetam. Sir, next slide. Yeah. So on the 6th day of life, MRI brain was done in the view of prognostication.
All right. 6th day, you can appreciate some concurrent changes in the corpus callosum, some radiating linear and focal abnormalities in the periventricular white matter and the centrum semiovale, as highlighted here on the first 2 images. And corresponding changes, some of them demonstrate T1 hyperintensities, as seen over here. There were some posterior hemispheric subdural hematomas, which is likely birth-related changes along the left parietal convexity and also some degree of the retrocerebellar regions. The main findings on diffusion are these concurrent changes in the corpus callosum, some degree of abnormalities in the plix on both sides, and focal abnormalities in the periventricular and deep cerebral white matter. On the T280 sequence, SAG sequences, SAG, you can appreciate there is a prominence of the vein of Galen and on the intercerebral vein. And on the corresponding stabilized sequences, we can appreciate blooming foci. So T2 hyperintensity out there and some blooming foci, some degree of slow flow or thrombosis demonstrated there. But if you look at the parenchymal changes, there are no significant abnormalities in terms of venous infarction or hemorrhagic changes in the deep brain nuclear structures, especially the thalami. Some prominence of the middle veins, not very significant. And again, you can appreciate on the axial SW sequences, there is again prominence of the vein of Galen and the internal cerebral veins. I think with that, we had suggested the possibility of a acquired insult, infective, most likely viral infection causing these concurrent changes with some secondary stasis of the blood in the venous sinuses. And then I think the follow-up was done. Some of the basic parameters came out to be normal, and the neurologist or the intensivist had specific questions. So yeah, over to you, Nikesh.
Yeah. So the basic blood parameters were normal. So our question is like, can only hypoxia can explain all the changes? Like there was thrombosis in the deep venous system. Whether it can explain. And by the time child was, by the time we did the MRI, child was clinically, the baby was totally fine.
So changes, diffusion, I don't think are hypoxic related changes. That is not typical. And then the next question is how much importance to be treatment for particle and thrombosis. Imaging wise, it is there, though no parenchymal abnormalities. And then expert opinion on conservation LMH. Sridhar says no role for LMW. Was CSF done? CSF or PCR?
Yeah. So CSF was done. It was normal. And PCR, CSF very first was sent. That was normal. Negative.
This is not the typical case of perinatal asphyxia, but I have seen a patient with this kind of corpus callosum and pons abnormality, and I think it's not completely ruled out. And don't forget the context. You have APGAR 1.5. The child had seizures, had respiratory distress, needed intubation. So this was a major perinatal, let's call it a hit.
Yep. And preterm tests, sorry. Yeah, sorry.
This
So
is
white matter
more
injury.
likely. This is more likely than metabolic or mitochondrial or whatever, I think.
Yeah, yeah.
Yes, sir.
So good that the child is improving. So yeah, goes with the non-IEM, non-genetic causes. Okay. And no role for LMWH, okay?
Yes, sir. Yeah.
I think that should have answered most of the questions.
Yeah. And sir, what about that cortical vein thrombosis? Should we? Because we.
Venography wasn't done. Nicholas, hypoxia causing venous abnormalities. Okay. Small medullary vein thrombosis. Hypoxia can cause white pain. Okay. Okay, I'm not sure of the relation of the hypoxia with the thrombosis of the veins, but I don't think we have any role of treatment for it.
Okay, sir. Yes.
Okay. Yeah. Rati, are there? I don't see Dr. Aarti on it. Okay, we'll wait. Maybe if she joins back later, we'll get back to this case. All right, Apura, what do you?
Yeah, so this child is a 9-month-old female born of third-degree consanguineous marriage. The child came to us with complaints of initially right eye inward deviation since 2 months of age, and there was delayed attainment of the milestone. Gross motor, the child had partial neck holding at 9 months, and there was some head shaking that was noticed a month prior. Partial rollover was attained and sitting with support when made to sit, and now the child was wobbly. Fine motor, he was holding finger when given in hand, had no dexterous grasp, not reaching out for objects. Language, there was just razzling sounds and making some sounds. He would recognize mother, she would recognize mother, fix faces, respond to sound, had occasional startles. There were no seizures, there were no jerks or spasms, good sleep, no swallowing issues, drooling was present, drooling of saliva. Bladder bubble was regular. The child was on rehabilitation. Perinatal period, the child was 2.1 kg, but otherwise it was uneventful. Examination, child had microcephaly, AF was closed, occipital plagiocephaly, dysmorphism, low set ears, frontal bossing, sparse hair, hypertelomerism, normal dermatoglyphics, and bilateral clinodictyly. There was bilateral non-paralytic esotropia and nystagmus present, no blink to light, no fixing tracking. There was significant CVI, and pupillary responses were present. There was mild temporal pillar on the right side, central hypotonia, and child had good anti-gravity movements, brisk DTRs. Child had partial weight bearing and cortical fisting. So it was a phenotype of global developmental delay, a motor more than cognitive delay with CVI.
Right. Scan done at 9 months?
Yes.
6 months? Okay, so you can appreciate that there is some degree of widened subarachnoid spaces, especially in the frontal convexity and the interhemispheric fissure. Periventricular white matter, there is some reduction in the periventricular white matter volume. You can appreciate the ependymal margins are touching the insular cortex. And for a 9-month-old, myelination is again, there is a delay in myelination. Some hyperintensity of growth factor, this can be normal physiological at this point of age, this age. But on the SAS sequences, the most prominent finding is you have diffuse thinning of the corpus callosum. Yeah, I think these are the main findings. Posterior fossa structures, at least the brainstem, the ventral belly is maintained. I do not think it is hypoblastic or atrophic. And also the cerebellum, the folial spaces are not evident, so there's no atrophy out there. And in terms of the height of the epidermis, it appears to be normal. So supratendular abnormalities, some delayed myelination, some cerebral atrophy, and also some the major finding is hypoplastic corpus callosum. No structural malformations or cortical malformations associated. Yeah, I think these were the main findings on the D2 axials. At T1s, we had similar findings: reduced periventricular white matter, cerebral atrophy. Yeah, no cortical malformations. No signal changes on the diffusion weighted sequences or established sequences. Child was evaluated and yeah, approved.
Yes. So this child on evaluation child had VPS 51. It is an autophagy related disorder. And this mutation is on exon 10 and it was homozygous autosomal recessive. So we wanted to check if this mutation is the possibility, if there is a clinical radiological match for this mutation.
Okay. Yeah, sir.
Yeah. So clinically in this mutation, they do have developmental delay, CVIs, auditory pathology, but liver is one important involvement. But in this child, when reverse phenotyping was done, LFTs were normal. So there was no transaminitis, no cholestasis. So is MRI match for this condition?
Okay, so the clinical findings, as you pointed out, these were some areas which matched. And as you have said, liver abnormalities, abnormal liver enzymes. But I think there are limited cases published of this gene. And I found only two cases of children with the MRI findings. So again, if you see the MRI findings, it looks somewhat like a PVL-like picture. You have periventricular varices with reduction in volume. Corpus callosum abnormality in both the cases. Some of these cases have a cerebellar hypoplasia or cerebral atrophy. But our case did not have any PCH or cerebral abnormalities. But the supratentorial findings are pretty similar to what we've seen in these two cases. But yeah, I'll open the case if anyone has any suggestions or comments.
Only a handful of cases have been published in the literature, so it's difficult to say whether this is a strict radiological match. And in the paper you just showed, these were siblings, and on the bottom line, I think the patient C and D was the younger sister, which was normal. So this was also a question whether findings are age dependent. I think it's not a perfect match, but it's a probable match. The clinical situation is not that specific, but I mean, I would tend to assume this is a probable match.
Anyone has any similar experience with the gene, PPS 51? ASPM is not a match. It's a microcephaly gene with simple gyration that is not seen in our case. Supratentorial findings, I think, are slightly non-specific, but as described in these literature, you had periventricular abnormalities and corpus callosum abnormalities. So in that regards, it matches. But the PCH, technically, it's PCH 13, but our case does not have a PCH. That can be variable, I think, if I'm not mistaken.
It can be variable. It's a spectrum,
Yeah.
I'm sure.
Yeah. It's like a PVL mimicker, right? I can look somewhat like a PVL. Okay. No comments. Apurva, if you're thinking of probable match, imaging wise.
Yeah.
Given the
segregation studies for the parents.
Yeah. This location of. Yeah. Okay. So Dr. Ayush says possible location of deletion seems to be hot topic for hotspot for intolerance. Yeah. Okay. So we'll wait for parental segregation and we'll update you on the results. All right, Nikesh, over to you.
Yes, sir. So this is 7-year, 11-month-old female child born of non-consanguineous marriage, presented with history of fever with cough for 2 days, around a week back. So after fever, within 5 days, she had right hand pain while writing for 2 days. After that, difficulty in walking next day morning, along with poor hand grip. Within 12 hours, child had bilateral upper limb weakness. And after 12 hours, child was having dropping of both eyelids, along with difficulty in breathing. So, with consideration of GB syndrome, child was received IVIG 2 gram per kg over 3 days in the outside hospital. Birth and development history is normal. So next slide, please. So at the time of arrival on neurological examination, child was conscious, following commands. Pupils were bilateral equal and reacting to light. Bilaterosis was there, and restriction of extraocular movement on upward gaze. The gag reflex was weak, and cuff reflex was also weak. There was generalized hypotonia. And if we talk about the power, bilateral upper limb power was 1/5 and lower limb was 0/5. There was airflexia, root pains were elastable, and planters were not elastable. There was no autonomic instability. So MRC score was 6/60, EGO score was 6/9, EGRI score was 7/7 at the time of admission. So we've done the handful of investigations. CBP was normal, RFT was normal, microplasma IgM, Lyme serology, flu panel were negative, blood culture was sterile. MRI lumbosacral spine was done on third day of admission, which showed.
Have you done CSF or have I missed your point? CSF?
Sir, CSF on clinical basis, it was, and after MRI, it was looks like GB syndrome only. So, sir, we haven't gone for the CSF at that time.
This is an important investigation in my mind. Very important.
Yeah. Okay, sir.
Because you have weakness and areflexia, paralysis.
Yes, sir.
You think of Guillain-Barré syndrome, spectrum, whatever. I'm not criticizing.
Yeah. Yes, sir.
All right. So on the MRI, no focal cord lesions or long cerebral myelopathy, but the main findings on the cauda nerve roots. As you can see, there's enhancement and thickening of the ventral and dorsal aspects of the cauda nerve roots. This is day 3 of illness, and so there's the possibility of GB syndrome, but other differences such as Lyme and infective causes to be considered.
So after that, plasmapheresis was done, 5 cycles over 7 days. For neuropathic pain, gabapentin was started. Tracheostomy was done on 8th day of admission in view of poor respiratory efforts, as well as need for prolonged ventilation. Child's ventilator parameters were adjusted according to oxygenation and ventilation parameters. As the lungs started improving, gradually ventilator parameters were weaned off, and child was shifted on BiPAP over next 10 days. Now conduction study was done on 16th day of admission, which showed absent CMAPs. Next, absent CMAPs in the right median, right ulnar and right peroneal nerves, and significantly reduced CMAP in the right tibial nerve. And sensory snaps and sensory nerve conduction velocities were normal. So the NCV was suggestive of acute motor axonal neuropathy variant of GB syndrome. So in view of poor respiratory efforts as well as paradoxical breathing, even after 1 month of illness, USG of diaphragm was done, which showed normal excursion on the both sides. Child was started on cycling with T-piece during daytime, and gradually duration of T-piece was increased up to 2 hours, and ABG at the time ABG showed increased PCO2 up to 47. So child was continued on BiPAP for 1 more week, and gradually T-piece cycling after that it was started, and serial ABGs and chest X-rays were done, and T-piece duration was increased gradually in day and night. Meanwhile, BiPAP was continued, and child required minimal oxygen support with TPs and BiPAP both. In view of very slow improvement in weakness, his MRC score was 35/60, and there was a asymmetric weakness, right more than left, and as well as lower limb more than upper limb. Second dose of IVIG, 1 gram, 30 grams was given over 2 days on the 47th and 48th day of admission. After that, repeat MRI thoracolumbar spine was planned in view of slow improvement and to rule out any myelopathy or radiculopathy.
All right. I don't think we did a contrast study, but yeah, these are the plane sequences. On the axial sequences, there was some degree of hyperintensities along the anterior ventral aspect of the spinal cord, predominantly located in the cervical and mid thoracic regions, as you can appreciate here. Yeah, these four images should depict the imaging abnormalities. I think before the plane study, no, there was no contrast study done. So these were the additional findings which were seen, which were not seen on the initial scan.
So now gradually child was having good respiratory efforts on TPs alone without oxygen. Repeat NCS was done on 52nd day of illness, which showed. So next slide, please. It was the same as the initial NCS, no conduction velos study, and that was suggestive of Oman variant. On 53rd day of illness, fluoroscopy was done, which showed normal diaphragmatic excursion on right side and slightly reduced excursion on left side. There was no obvious paradoxical movement and no obvious eventation. Currently, this is the day 68 of illness. Child is off oxygen and BiPAP since last 16 days, tolerating TPs both during day and night time. There are no autonomic fluctuation, no desaturation, but MRC score is still 35/60. She is able to take semi-solid diet orally. So we just want to know whether we can consider any other differentials other than anti-onset myelitis, because the recovery is very slow as compared to other cases which we have seen in the past.
So after second MRI, it was CSF done?
No, sir. It was not done, sir.
The recovery.
Yeah. Sorry.
The recovery is slow, I agree, but further recovery is definitely possible. I would be rather optimistic. I mean, it can take 1 year to recover after such a severe initial presentation. And I have no alternative. I think it's a kind of, whatever you call it, myeloradiculopathy. Yeah.
Yeah.
Yes, sir.
So just imaging differentials, I think as was asked, GBS is the most common one, but other viral infections can cause what I call an root enhancement. And in terms of anterior horn involvement, yeah, again, these are the common findings or common conditions which can present with anterior horn cell. But I think given that the initial picture showed GBS-like picture and the MN variant can also have these changes, I think it might be a single pathology rather than dual. Shweta agrees with Ivan. And there be radiological lag as initial scan being fraud involvement.
Yes, there can be.
Yeah.
To answer Ayush's question also, it cannot be CIDP because even if we take an acute variant of CIDP, that will have demyelinating NCS. Secondly, they won't show any improvement. So if there is no improvement in Aman variant of GBS for more than 8 weeks, then we call it might consider an ACIDP. So he is improving over 8 weeks. So we will not consider ACIDP. This will be Aman variant only. They do improve over 3 to 6 months.
And CIDP is progressive nerve root enlargement or thickening. That was not seen in our case. It is imaging.
Yeah, that is also okay. Yeah, agree. This is Aman residual.
So any other treatment modalities or medications to be given or?
Nothing.
Any other
Physio.
approach could have been used. Physio is ongoing, sir. Physio is ongoing.
The supportive physio, thiamine, B12, vitamin D, calcium,
Okay.
all those things.
Yeah,
Something
that
major.
has been taken care of.
And other approach in literature, there is something which is known as zipper method. So where they alternate plasmapheresis with IVIG. That
Okay,
has
over
shown
9 days.
improvement in
Yeah.
some cases. And currently, what we practice is if the child is more than 50 kgs, we directly go with Plex in Aman variant. So that has helped us achieve a cost economy in terms of IVIG, because 100 grams IVIG is around ₹1,00,000. So we directly go with Plex in them, and have seen that the ones started on Plex had a better improvement as compared to ones who are given IVIG alone. So rather than giving a second dose of IVIG, maybe a Plex would have helped. But that is just theoretical. Anything would have it might be same also.
Okay, sir.
But yeah, second dose IVIG also literature wise, there's a trial known as SID trial, second dose immunoglobulin in GBS trial. They have shown no improvement with second dose of IVIG, and rather who got second dose had poor prognosis compared to those who received only one dose. So if you want a randomized control trial, then this is the evidence, but in adults, not in pediatric. So second, if IVIG has failed, then better to go with Plex.
Okay, sir.
Thanks, Sridhar.
Yeah. Thank you, sir.
Dr. Udani or Dr. Namrata, any other comments?
Sorry, I just joined.
Yeah, this was an AMA variant of GBS.
Okay.
So later on has some anterior horn cell involvement. But child, I think over a period of 2 months.
He had anterior horn cell involvement.
Yeah, on the follow-up scan. So this was the first scan. The first scan did not have any cord abnormalities with typical GBS-like picture on the cord equine nerves. Plex was done, I think, plasmapheresis was done for 5 cycles or 7 days. And over a period of 2 months, child is gradually improving, but this was the most recent scan done 10 days back. We developed these tiny areas of hyperintensities on the ventral aspect. So repeat NCS also demonstrated.
The problem is even enteroviruses can cause the enhancement of the roots.
Yeah.
Often it causes enhancement of both anterior and posterior roots, but anterior horn cell is very unusual in AMAN, because AMAN generally, when you have anterior horn cell lesions, that means your prognosis is not great. And AMAN is generally, the prognosis is as good as AIDP, except that it takes a little longer.
Yeah.
So I'm a little worried about if this is I heard the word asymmetry, so this might be actually enterovirus or some other viral myelitis, and sometimes the lesions on the anterior horn cell are picked up later, when they become more cystic. So I don't know. Just tell us how he does in the future. If he improves completely, fine. AMAN, otherwise.
Okay, Nikesh, please give us an update in the next meeting or subsequent meeting.
Yeah, sure, sir. Sure.
All right, Apura, over to you.
We had a 2-year, 10-month-old boy born of non-consanguineous marriage. He presented with moderate grade intermittent fever for 5 days. And on day 5, there was dull activity. So for above complaints, he was admitted at outside hospital. So this event was dengue, the first this event where the child had 5-day fever and mild encephalopathy. So it was a dengue encephalopathy. And past history, he had some episodes of cyclical vomiting episodes where he would have vomitings persistent 5 to 6 times for 2 to 3 days, and every time there would be abdominal discomfort. He kept dull, had sweating, and then he would improve. In the current admission, the child he had encephalopathy, and the child was admitted in PICU, and he was offered symptomatic treatment. He did not require intubation. It was a mild encephalopathy, and there was mild asymmetry in the examination. So initially, MRI was done. Once the MRI is there, we'll discuss.
Yeah. The 2 MRIs done, I think, a couple of days apart. I've put in the most recent one. All right. So this was the second MRI, and you can appreciate that there is abnormality in the left basal ganglia capsular white matter. demonstrating some areas of restricted diffusion, some central areas, and also along the periphery. But if you look at the SWS sequences, majority of the abnormality demonstrates blooming. So predominantly hemorrhagic components out there. Some cystic changes with some perilesion edema. Also the subcortical cortical regions along the left posterior temporal lobe demonstrated some punctate areas of blooming with blastonic edematous changes. So predominant changes in the basal ganglia. Again, in the occipital horns also there was some area of restricted diffusion especially on the right side and along the ependymal margins. So these were the main findings, but predominant changes of the left basal ganglia capsular white matter. This is T1 non-contrast sequence, and on the post-contrast study, I think a very negligible enhancement demonstrated. So T1 signal of the non-contrast study carries through. No intact malformations in terms of on the contrast study. And again, there's some vasculitic type changes along the subcortical cortical regions of the left posterior temporal abnormality. Midline Sag, the structures are intact. You can appreciate some degree of volume reduction, but nothing else significant out there. So as Apurva has mentioned, there was leukopenia with thrombocytopenia. The child was dengue and S1 positive.
So the question was thrombocytopenia was the lowest threshold was 79,000, and child had mild encephalopathy. It settled. There was mild weakness of the left upper limb. So our question was that is there some AV malformation? Because with this thrombocytopenia, it is difficult to explain. PTINR was negative, BTCT. All the blood parameters were not significant enough to cause a bleeding from the clinical point of view.
Okay, so I think the next question was any other sequences at this point of time not required. A significant or an IDAS would have been found out on the contrast sequences. Only maybe a micro AVM would have been missed. So CT angiography or DSA would be more specific for that. But at this point, I think the contrast is sufficient to rule out. That AVMs can be ruled out, or at least an intact AVM can be ruled out on the contrast. But if you want to look for any micro AVMs, then CT angio or a DSA. And there are some published cases with the similar findings, but what we've seen in dengue encephalitis, especially with the one in the middle out here, they've attributed it to endothelial dysfunction and vasculopathy related changes. And this was a case I think discussed a couple of years back, had significant hemorrhagic changes related to dengue. The question I think from the clinician's point of view is, are these primarily dengue-related changes or any alternate pathology is to be considered?
Yeah.
Yeah, with that I'll open the case.
Heterogeneous to be a hemorrhage from a malformation.
Yeah.
I mean, there's some edema, there's almost like a capsule there.
Yes. But it doesn't enhance or kind of.
There could be a hematoma which is resolving.
Yes.
With edema around it. And that stuff in the occipital horn is blood only, is it?
Yeah, it is blood. It didn't enhance, and I don't have the sequence here, but it shows some blooming on the external side. So any experience with dengue-related basal ganglia hemorrhagic changes? I think that was the main question.
I haven't seen.
So our primary question was, is there a need to do a CT angio or a DSA? Should that be offered, or we should just consider this to be dengue related?
Only thing was that only point that for a malformation would be, you said you have recurrent episodes of vomiting. Are those vomiting episodes associated with headache also? Is this kind of thing is having had also some sort of hemorrhage or what?
But the child is 2 year 10 months, so headache would be difficult to elicit.
Correct. So maybe vomiting may be part of this bleeding thing only. Maybe you need to.
And there are two lesions. If it was single lesion, maybe, but there's one over here also. So. And it shows some punctate microhemorrhagic foci. So,
Oh, posterior. Okay.
yeah.
There is unlike. Then it's probably this way.
Yeah.
Mind to wait for some time and do a repeat scan and see
Yeah.
how it evolves.
Okay.
I would think 4 to 6 weeks should be sufficient for a follow-up. Then we can take it.
Sure.
All right. Dr. Tarang, if you're there, over to you. Dr. Tarang, are you there? If Aarti is there, we can go back to our case. Aarti, are you there?
Yeah.
Okay. We'll go back to the case then.
Hello.
All right. Yeah, Dr. Aarti, over to you.
Yeah. So this is the case which was admitted around September 20th of this year. This is a case of a 15-year-old girl who was previously having no significant past history. She's studying in 10th standard, 15-year-old, and she was admitted into the PICU on 20th September with first episode of unprovoked seizure. It was actually a right focal seizure where she was actually in school and she had a sudden fall while sitting with focal eye deviation to the right side, severe vomiting, and focal jerking of right upper limb, which was lasting for 15 minutes and even longer. And she was loaded with levetiracetam and then referred here. She was loaded with levetiracetam and then she was there for 1 day in the outside hospital and then she came here to motherhood. Initial CSF analysis done outside was normal and MRI was done during the first admission. Are you going to show the MRI now, sir?
Yeah. Okay. So MRI demonstrated a single focal lesion in the gray-wire matter junction in the left posterior temporal occipital lobes with significant vasogenic edema. There were some central areas of flare and T2 hypointensity with some peripheral areas of hyperintensity out there. On diffusion, there was peripheral enhancement of the wall of the lesion. On T1, you can appreciate central hypointensity with some isointensity of the capsule. No blooming on the SW sequences and no increased perfusion on the perfusion studies. These are thin slice sequences of the lesion, heavily weighted T2 weighted sequences. You can appreciate some T2 central hypointensity with some heterogeneous hyper to isointensity along the periphery. Post contrast, can appreciate thick enhancement of the lesion. Spectroscopy was done. I think spectroscopy demonstrated lactate peak out there and a slightly elevated alanine peak. Rest of the peaks were, I think, are the normal. Can take it as normal. So these are the main findings of the scan.
Okay. So she was initially treated with the anti-edema measures because there was severe perilesional edema, as we can see. And after the MRI report, MRI was preliminary reported as neurocysticercosis with a scolex visible inside, and as the findings that were described by Dr. Nihaal Reddy. And she was started on albendazole and dexamethasone, followed by oral prednisolone, which was slowly tapered over a period of 4 weeks. Then after completion of the course of steroids, she was readmitted on 3rd November. That is almost more than 5 weeks from the first time, for 5 or 6 weeks from the time of first illness. She was admitted with a breakthrough seizure. It was a right focal seizure again, but it was a briefer episode than before. And this time she was admitted, and that time we had done a repeat MRI and a CSF analysis also. MRI will be discussed. Regarding the CSF, it was only showing total count of 2 cells with 100% lymphocytes. CSF sugar was 94 milligram per deciliter, which was normal. Protein was 29.5, and CSF chloride alone was higher range, higher than the upper limit which was mentioned. And CSF meningoencephalitis panel was negative. CSF gene expert was negative. And serum cysticercosis IgM was also negative. And IGRA was also done because of the evaluation for a ring enhancing lesion. So IGRA was also done, which was negative, and there was no AFB isolated from the gastric aspirate also. HIV was negative. And EEG was showing electrophysiological dysfunction over the left occipital region. And she was, this time she was treated with anti-edema measures, and pulse methylprednisolone has been started, and we have planned ATT. So I just want to make sure whether it, like, regarding the findings of both the scans
The
before
second scan after how many, what's the interval? Okay.
Um,
2
second
months?
scan was on 2nd November, so almost
2 months.
5 weeks.
2 months.
Yeah. 5 weeks or 6 weeks.
Okay,
Yeah.
got it. Okay. So on treatment,
Has
on
been retreated with a course of with the course of albendazole plus
albendazole.
praziquantel.
Got it.
But ATT also, we are based on the discussion, I would like to take it forward.
All right. So there's interval progression in terms of the size of the lesion. Some central area of discrete diffusion along with the periphery, which was seen previously. The edema remains the same, or maybe slightly more prominent. Some punctate areas on the blooming foci. Peripheral enhancement, again, some crenated margins out there, some internal separations. Yeah, so the lesion hasn't reduced. In fact, it's slightly increased. Again, T2, you have heterogeneous signals in the central regions and some diffusion changes and peripheral enhancement as seen out here. So the main question is, are we still dealing with NCC as what was previously thought of on the first scan? Or is it possibility of a granulomatous lesion, particularly TB? Is that right, Akati, or any other?
Yes, I want to know whether it's NCC or tuberculoma. Like, yeah, one. So I basically when we went back to the first report, there was a few findings mentioned, like that scolex is present.
Finding it hard to view the scolex, and it should have been T2 hyperintense rather than hypointense on the T2s and the flares for NCC.
Hello.
Yeah, so if you look at the signal intensity on the first scan, these are the T2s and the flares. So on the T2s and flares, NCC should have a hyperintense signal because the cyst. Here it is more hypointense, so more granulomatous lesion. So I'm not sure. And also the scolex, I'm not able to appreciate the scolex on using this. And it has progressed given the medication. So that is again another point which is slightly against it. So these are the differentiating features of NCC versus tuberculomas. If you look at the first scan and look at the image out here, pretty much resembles what we have seen on the first scan. And usually TB, I mean, NCC are usually less than 2 centimeters is what we take as the common handle. And so I think there are cases for slightly larger lesions than what we have seen. So yeah, I'm not sure if it's NCC, but maybe another granulomatous type lesion to be thought of. So,
no, are the points favoring in favor? Are the points more in favor of tuberculoma at present?
Yeah, tuberculoma one, but other granulomatous lesions also to be considered. I think someone has put it amoebic granulomatosis, but I think the clinical picture is slightly more severe, if I'm not mistaken.
Yeah, and other than breakthrough seizure, she didn't develop any other focal neurological deficits, and she's absolutely well. And she's an immunocompetent child, so we have not done toxoplasma also. And yeah, and the meningoencephalitis panel is also negative. So is it a good? I mean, are we in a position to start anti-tuberculous therapy based on these findings, or because the size of the lesion is increasing and compared to the first scan, and the child has, I mean, if it is going to be a tuberculoma, she will worsen if I'm going to continue steroids without ATT. So is the MRS showing a well-defined lipid lactate peak now, the second scan?
I don't have a second one.
No, second scan, I had sent an MRS also.
Okay, can you check the report? Sorry. Sorry, I don't have that image then.
I can resend it in person.
Sure. Anything mentioned on the report?
No, the first scan they have mentioned it as NCC. Second scan they have mentioned
no, the MRS. The MRS.
MRS they have mentioned as a lipid lactate peak.
Okay.
In the second scan, yeah.
There's a lipid lactate peak over here also. The lactate peak predominantly.
Okay.
Is there any weight loss, fever, constitutional symptoms, any contact?
No contact and constitutional symptoms. There was no fever even when she had the first episode of seizure, even 2-3 weeks before, nothing of that. So she just came directly with one episode of seizures. And then now she's on 2 anti-epileptics for seizures.
I think it's probably TB, but if you can do a CT scan, abdomen, chest, it will give a good idea.
Yes, sir. We have done an ultrasound abdomen and that was normal. And CT chest, we did not go ahead because she never had any respiratory symptoms.
You
Even,
have symptoms, but you may have a additional focus, which will make you more sure. But it's, I mean, looks like a tuberculoma with a
Yeah.
So I think it's can treated if you just walk otherwise.
okay, sir. So I'll go.
I would start with the ATT radiography. So almost going into cascading phase with diffusion going centrally, and the heterogeneous signals out there.
Okay.
So maybe you can start with the ATT and we can have a follow-up in maybe 3 months.
3 months later, we can do a scan after the completion of intensive phase.
Yeah.
Okay.
And if not responsive,
at that time, we'll have to do an MRS also in contrast of the.
The same parameters, which you have done here.
Okay.
You say toxoplasma, okay, but not immunocompromised. Common being common, it could have been more central in location if you had toxoplasmosis. Lymphoma unlikely, yeah. Dr. Jeshi mentions a similar case 2 days back, 3 days history, ongoing fever. No contact history, all work for TB negative, but started ATT, now she is doing better. Anti-MOG, the card says anti-MOG. I've not seen a focal lesions of MOG, but.
I hope we are not missing any gliomas also. I mean, since it's a ring enhancing lesion, I am just thinking of all the differential diagnosis.
No, the choline is pretty normal.
Okay.
So.
Yeah, I think demyelination also can be. I think Taj mentioned that, but the choline is normal. It's very suggestive of not glioma or a demyelination.
So I think next step. Sorry.
Among NCC and tuberculoma, I think tuberculoma has a predilection for the gray-white matter junction, isn't it?
Both.
Okay.
So it's usually hyperintense, as mentioned out here. It should be hyperintense on the T2 sequences. The center should be hyperintense. Our child does not have an hyperintense. Like there's more hypointense.
Okay, so it's more in favor of tuberculoma then.
Yeah.
Okay.
So we can start ATT and we can do a follow-up.
We used to have this argument whether it's TB or this or for years. Yeah. And the answer never came through. So finally people just got tired of that. And finally just follow up and find out. And I think if you followed up and you found that it looks small and increasing and it's shaggy and there's edema and there's a big peak, I think just start treatment.
Okay. Yes, sir. Thank you for your input, sir.
Okay. Thanks, Afi.
Thank you. Yeah.
All right, if Dr. Tarang is there, Dr. Tarang, are you there?
Hello.
Okay. Yeah.
I'm there. Am I audible?
Yes, please go ahead.
Yeah, so this is a 11-year-old child, a single episode of unprovoked seizure in September 2025, no neurological deficits, uneventful perinatal periods, no developmental issues, going to school regularly. EEG done elsewhere was showing no significant abnormal discharges. He's currently on Levipil and no further seizures since the first episode after starting Levipil. This is more of a radiology discussion, and basically the first MRI had some findings for which we decided to observe and get a repeat imaging done after 6 weeks, where the lesion kind of changed its appearance. So maybe Dr. Nihaal can elaborate on what the lesion looks like here.
All right. So T2, these are non-contrast sequences. T2, you can appreciate the subcortical regions. Cortical regions are predominantly in the temporal lobe. You can appreciate the abnormality out there, for focal abnormality. Does not show any residual diffusion, predominantly facilitated diffusion out there. And on the fluid sequences, some areas demonstrate fluid suppression or cystic changes or refractory changes. So this is, I think, the likely cause of the seizures. I think on the SW also did not demonstrate any calcification or hemorrhage. I don't think, yeah, we have a contrast study too. So on the T1 sequences, again, you can appreciate the cystic nature of the lesion, seated in the subcortical, predominantly in the subcortical regions of the temporal lobe. Post contrast, there was no, I mean, I cannot appreciate any enhancement or significant enhancement. There's no associated meningeal or dural enhancement also. So that was the lesion in the temporal lobe. Any interval treatment or medication given?
No,
Before the
nothing,
second
nothing.
scan?
Just the child was on Levipil. We had doubt of it being a DNAT with
Yeah,
dysplasia and or low-grade glioma.
yeah.
But we decided to
And
get a repeat imaging after 6 weeks for
and
the child with MRS. Yes.
and timing of the scan in terms of seizure, last episode of seizure.
Child till now, and that was in September. And since then, he's never had a seizure again. But he's been on Levipil since then.
So the first seizure, I mean, I'm just asking the seizure
So
timeline and
the scan. Okay. The seizure has
uh,
happened on 20th. The scan has done approximately 20 hours post seizure.
okay, got it. All right, okay, fine. So no interval medication done, and then we have a follow-up scan. All right, there's some family history of parasitic infection in the younger sister who takes albendazole every 2 to 3 months. And then this is the follow-up scan. In terms of the follow-up scan, you can appreciate that the lesion has demonstrated interval reduction in the size and also in the edematous changes. You can appreciate only some focal area of cystic change out there on the phase sequences. Again, on the T2 sequences, there is some residual changes, but in terms of the lesion or the abnormality in terms of first scan, there is some reduction out there. Again, no diffusion abnormalities. Spectroscopy demonstrated, you can appreciate there is some elevated choline peak out there, a lipid lactate peak out there. Some heterogeneous signals on the spectroscopy, but one of the focus demonstrated some signals which might be suggestive of neoplastic etiology. So the question I think Dr. Sarang is asking is, are we still dealing with a glial or a glioneural tumor, or is it an alternate pathology? Is that right?
Yes. So basically, I was thinking more on the lines of it being a transient. One was, of course, NCC, and second is it's just transient changes post epileptic, post seizure, which has gone away after 6 weeks. There has been a significant reduction and change in the signals on flare as well as T2 for this child. So not completely convinced it to be of neoplastic origin, in spite of this spectroscopy.
Got it.
Yes.
So NCC, I mean, some enhancement would have been there. I think that's not there. The morphology also does look somewhat not typical of what we've seen in NCC. The question is whether the first scan had combination of the lesion and the edema with the seizure. Hence, I had asked you the timeline of the seizures. And then once the seizure is controlled, whether the vasogenic edema is reduced, but there's still some persistence. I mean, there's some, you can appreciate there's some degree of residual change out there.
Okay.
Whether it's still to consider low-grade glioma or a glial tumor is.
We have planned for a repeat imaging after 3 months as of now. But I was hoping that if some other differentials could be given apart from, or would it really be a transient post-ictal change that we had seen in the first one? And this is just resolving transient post-ictal change, and we may see a normal MRI after 3 months. I'm not sure. The cortical thickness, I could not make out it to be so significantly high to, like on the first MRI, the cortex definitely looks thickened. But on the repeat MRI, the cortex thickening is not very convincing. It's more still like some edema persisting there, is what I was thinking. What is your take on it, Dr. Nihaal?
I would still go with the lesion.
Okay.
And I mean, 20 hours, I think there would have been some diffusion changes also if it was ictal-related change by edema.
There is some diffusion change in the first MRI.
Yeah, so this is the ADC sequence. And
Okay,
all
it's a
of
shine
it
through.
is, it is shine through. So it's predominantly showing T2 hyperintensity. So given the acute phase, and why would only the temporal lobe be showing lesions? There are more common areas showing ictal-related changes like thalamus or or the mesial temporal lobes. Slightly odd for.
Can you repeat the history? Was that a single short seizure?
Yeah.
Single short seizure, generalized tonic-clonic one,
Okay.
associated with loss of
But
consciousness, lasting only for
would you
5
would you
Yes.
expect from a short seizure such a lesion with edema?
No, sir. So it was very unusual history. Child came for a neurosurgical consult for surgery based on the first MRI.
Yeah.
We did not surgery because we weren't sure that it's really a lesion there. We wanted to get a repeat imaging done after 6 weeks, as the child was completely asymptomatic. And the repeat imaging showed some resolution. We still told to be on follow-up, and we have still not offered any intervention for same. So
I think your management was perfect so far. And the repeat MR is necessary, I think, sooner or later.
Yeah.
Yes, so 3 months is the current timeline that I have told them, but if any other suggestions are there.
3 months is sufficient, Dr. Tarang, but if the child has again a bout of seizures, then I think that would warrant a earlier scan.
Yes. So how would a transient post-ictal change on MRI, how can we differentiate it from a low-grade glioma or a focal cortical dysplasia?
Okay, so firstly, the transient ictal change will be more cortical than subcortical. It would have been showing diffusion changes at least on the earlier phase or the acute stage. Our child has more, you can appreciate more focal abnormality. It is more subcortical than cortical. If you appreciate on the flare sequences, the cystic changes are not seen on any ictal-related changes. So it would have been hyperintense on flare. It wouldn't have shown these cystic areas of transient edema. So this I can appreciate. I mean, I could say that this may be some vascular edematous changes there, or coupled with maybe a lesion out there. But this flare suppression is not typically seen in only a transient ictal-related change. More diffusion changes, more cortical abnormality would have been there. Yeah. So even on the T1s, it's more subcortical over there. So common being common, cortex is more commonly involved than so here it is more subcortical. Yeah, I wouldn't say it's transient, but I would say some component of edema was there, which has maybe come down, but there is still some persistence of the abnormality in the subcortical region. And if you're terminating as gliosis, the circle spaces are pretty well maintained. The cortical thickness is also pretty well maintained. So I think that would have been slightly atypical for a gliotic like abnormality. And why would gliosis be there only if there was one event of seizure? So I would still keep the differential of glioneural or glioma, low-grade
But
glioma.
if it's a lesional thing, would it remain static? Like even if it's an FCD or low-grade glioma, wouldn't
FCD
it be
again
static?
Unlikely.
Yeah, FCD again unlikely.
Yeah.
Yes.
Yeah. What I'm saying is, sorry, whether the initial changes had some edema along with the lesion, which on the follow-up scan only the edema is resolved, but there are some cystic components which are still persistent.
Okay.
Is it possible that this is the first thing with the cystic area if you forget about the edema, it looks like it's tumor.
It did look like a tumor at that time.
Tumor.
Hello.
Tuber. I'm not saying tumor. Tuber.
Oh, tuber. Oh, okay, sir. But
I had a problem with the edema because disappearing edema is very odd. Otherwise, a tumor sometimes can have a surrounding white matter change and all this. But how will it disappear?
Child clinically wouldn't the child be having more refractory seizures? I'm not sure.
Necessarily. There are these form for the TS. where you may get one tumor only, that kind of thing. So it's not always the case. But I think the main point against it is the fact that the second scan shows a resolution of the white matter change, and I don't think it's post-ictal.
Okay, sir. Okay, sir. Okay, sir.
So so the follow-up will give us an answer. Rang, if it is still persistent, then maybe
yes, we can consider. Okay.
but ictal edema would be less on the consideration.
Suppose the follow-up scan does show a similar kind of a picture, is it good to go for a surgery to get a biopsy?
Yeah, I mean the location is pretty convenient, I guess.
Location is definitely convenient. Yes.
Yeah, I would do that.
Okay. Thank you.
All right, so last case, Kirti, over to you.
Yes. So this child presented to us in the neonatal period. The perinatal issues, immediate perinatal period was uneventful. Child was born at 2.5 kg, cried immediately. But on around day 15 of life, started having neonatal seizures. And they were multifocal clonic jerks, multiple episodes, and required 2 anti-epileptics for the control. And the child got discharged also. The child was fine at the time of discharge, was feeding well. The quality of movements were well. Child looked alert. And for a month, the child continued to be so. But 1 month later, the mother comes back saying that child has become very dull and is also not moving much and is having some different type of seizures. And that's the video of the second type of seizures what the child was having. So the child would have sudden flexion of lower limbs and perioral automatisms, which would last for around 10 to 15 seconds. And child wouldn't respond during this time, and these events would happen multiple times a day. So the first time when the seizures happened on day 15, MRI was done elsewhere. That was reported as normal. EEG was normal. And because the seizures got controlled also, so we didn't repeat at that time. But when the second type of seizure started happening at around 3 months of age, we repeated the imaging that will be discussed. And over the period of time, the seizures have been refractory. The child is not gaining any milestone. The child is around 1.5 years now. There is no neck holding, no rollover, and progressive spasticity has started developing. Tone is progressively, every time they come, there is progressive increase in the tone of the lower limbs more than the upper limbs. Vision is also poor. There is no fixing tracking. There is nystagmus. So there is a component of CVI also. And maybe we can discuss the imaging and then further work.
Okay. So I have 2 sets of images, one in the neonatal period. So I think this was done a couple of weeks into is that right?
This was done at around 3 months of age when the
3
second
months.
type of seizure started happening.
Okay, so on you have the diffusion and ADC panel sequence out there, and you can appreciate some areas of edematous changes, particularly in the thalamus and also in the corpus callosum. Also along the mammary bodies, and on the ADC, you have some degree of hypointensity in the thalamus. But yeah, these were the main findings which were seen on the ADC and the diffusion sequences. So central areas of edematous changes. And on the T2 variant sequences, even for a 3-month-old, you can appreciate the corpus callosum is thinned out on the SAT sequence out there. We thought of possible some particle abnormality out there, not pertaining to polymicrogyria or recent cortex, but the cortex appeared slightly more clumped up together, especially in the frontal lobes. The Sylvian fissures were under-localized. So these were the main findings on the T2 and T1 variant sequences. The corresponding nothing abnormal on the T1, which are not seen on the T2 variant sequences. And on the SWI sequences, there were no areas of blooming out there. With that, I think, basic workup was done.
No. Yeah, the CSF, no, actually, this is not of this case.
Oh, sorry.
It got mixed up. No, the CSF we had done, that was normal, but we didn't investigate this much. No.
Did you take a veteran?
Sir, I tried. The child is on Vigabatrin now.
No, at
So
that
the
point of time.
changes might be
Yeah.
because of the Vigabet.
No, sir. At that time, no. I had tried just pyridoxine before this imaging.
Okay. Then we have a follow-up scan 1 year later. Is that right, GP?
Yes, sir.
So some progressive, nothing on the diffusion, maybe some residual stages over here on the left side, but it shows the T2 shine, so it does not reverse on the ADC. Central tegmental tracts is nothing normal physiological for this age. Better appreciate the findings are better on T2 weighted sequence. You can again appreciate interval volume loss, particle volume loss with some hyperintensities in the white matter. At this point of time, the malformation doesn't appear to be as conspicuous as the previous scan, so that I think can be ruled out. So some cerebral volume loss, some periventricular and deep cerebral hyperintensities, and again you have this reduced volume of the corpus callosum. No changes on the ST5 sequences. Some positional phagocephaly on the right side. So genetics was done, and PTO2.
Before genetics, we had done the basic metabolic workup also. The VBG, lactate, ammonia, they were all normal. TMS was normal. And GCMS showed increased excretion of dicarboxylic acid and excretion of lactate. But blood lactate being normal, that was not correlating. Then we went ahead with genetics and we had these two variants detected. The first one called RMT was heterozygous autosomal dominant VOS, combined oxidative phosphorylation deficiency. And the second one was heterozygous autosomal recessive. So we had just one copy detected for this one. But both these were not clinically matching the phenotype because the first one, the literature says, the OMIM phenotype says that they have a lot of skeletal abnormalities, hypophosphatic rickets, which this child didn't have. And the imaging features also were not matching. And the second one, the carnitine deficiency that is associated with heart abnormalities and even hypoglycemia, but never was hypoglycemia detected in this child. So, and clearly it says no dicarboxylic aciduria. I don't know why do they mention that. And this child had dicarboxylic aciduria. So it was not matching, and there is no improvement. Now the basic phenotype right now is that the child is having multiple episodes of seizures. With addition of new anti-epileptic, the seizures settle for maybe a month or two. Again, the parent comes back that the seizures are coming back. I have tried Vigabatrin, I have tried pyridoxine, pyridoxal phosphate, biotin, even mitoQ7. The child is already on mitoQ7 also. Lacosamide I have tried, perampanel I have tried. But development wise also there is no progression.
And that finding of progressive spasticity is there. He's becoming spastic or rigid day by day.
Yes, progressive. So over the last 1 year, every time I examine, I find that the degree of spasticity is increasing. Imaging doesn't explain completely the phenotype, nor have got any answer in the genetics. So
there is
that's
a
why
gene known as FRAT1, BR81 gene that causes multifocal seizures with progressive rigidity. Sort of this. Just read about the gene, BR81 gene. The phenotype
BR81.
clinically matches that. Yeah, and you can ask for an reevaluation and check for that gene whether it is covered or not. So that's the one thing I could think of based on the history.
Kavita's parental study is done? I don't think what is done.
No, it's not done. Not affordable. This also I got with great difficulty, so I've not done parental studies.
Imaging wise, I'm not. It doesn't point out to any specific abnormalities. More progressive neurodegeneration with some white matter changes and thinning of corpus callosum.
And EEG also repeatedly EEGs are showing some low amplitude spikes, multifocal spikes with little low amplitude background, but it doesn't give me much more, any more information on it.
So that one is a DE spectrum. Yeah, I think that was interesting.
BRAT1. D spectrum. Okay.
Okay. Yeah.
PRC1 associated. Okay. Okay. So maybe I'll ask for a reanalysis.
Trapopathy is possible clinically. I'm not sure. If anyone has seen
Trapopathy.
they
Wouldn't
usually
they basal ganglia changes and brainstem changes too? Trapopathy.
more of a neurodegeneration, but the seizure phenotype is more. I think more.
Okay.
There will be dark basal ganglia thalamus, but not always. But I think this is more imaging wise is less specific. Dr. Kavita suppose DE genes covered.
Okay.
What was
Yes,
done?
yes, it was. Yes, the phenotype mentioned to them was DE actually. It was covered. Anyway, I'll go back, reanalyze, and as ma'am said, WGS with trial. I think if we don't get anything in this one.
Yeah. So whole genome, which even Ayush mentions.
Okay.
So unfortunately, imaging not very helpful, but yeah, some suggestions also which might be
Okay.
genetic
Okay.
information.
Yeah. Ringed chromosome. Yes, we have checked ringed chromosome karyotyping. Basically, we have done, which is negative. Yeah, it was done. Karyotyping was done.
All right. I think next step will be whole genome sequencing with
Trial. Yeah.
yeah, and maybe
Okay.
parental
Okay.
testing after. Okay.
Yeah. Okay. Thank you very
Okay.
much. Thank you.
Okay. Thanks, Kitty. So I think that should conclude. We'll meet again in 2 weeks' time. Thank you, everyone, for your active involvement and participation. Banerjee, you can end the session. Bye again. Take care. And belated
You too.
birthday
You
wishes.
too.
Belated birthday wishes. Sorry, I missed that.
Thank you again for careful preparation. It was very informative.
Okay. All right.